And actually, just before, I just wanted to amplify Lipika's point, which is a point that I've discussed with her a number of times, is that to report genetic data associated with the trial is great, but it actually needs to be detailed. So it doesn't really mean a lot if a mutation is reported as being mutated with no information about what the variant is. For example, in the current trial, it's not possible to know whether a co-occurring mutation with the FGFR fusion tended to be non-responsive or responsive. And second of all, knowing what variants of FGFR are altered, those would allow us to create hypotheses going forward for what might create a priori upfront resistance. And second of all, since there's so many ongoing trials, even though there's only a limited number of patients per trial, this collective genetic data, if it were available, would much more likely allow us hypothesis for what are the basis for resistance or upfront sensitivity. So nevertheless, the work is terrific, but I just encourage you to think about a mutation a V to A mutation isn't the same as necessarily a stop codon and so on. So we need that information for as scientists to interpret the work. Now let's take some questions.
Bing Tay, I actually enjoy your talk very much, Bing. So I think you probably one of the leading authority to comment on the complexity of the genetic landscape. I think one of the things that we're struggling in the past few years is really the coexisting mutations, as well as what mutations are actually truly mutually exclusive. I think understanding that one clearly will have significant impact for us as a clinician, to developing the combination strategy, which I think Peter also alluded in his talk. So I want to hear your thoughts, based on everything and I think give us some insight about the codependency as well as the mutually exclusive mutations, if you will.
Thanks, Dr. Zhu. First of all, we used OV and non-OV cases by contrast and compare them, and then truly we see some of the alterations that are specific for one group or another. For example, FGFR fusion, as I show, is very rare in the OV-related cases. We did see some of the sort of coexistence mutations and mutually exclusive, but I mean, one of them is like the BAP1 together with, if I'm not mistaken, it's IDH, I think. But in the mouse model, I think Dr. Scott Lowe may tell us more about this. It doesn't pan out the coexistence. I think it's the IDH plus KRAS. So it clearly shows that we still have a lot to learn about how the codependency or mutually exclusivity of the genes. But definitely, I think the underlying etiology does play a role in distinguishing between what alterations are involved. I mean, another one is IDH. I mean, a lot of interest in IDH, but again, it's very uncommon in the OV-related cases. So the other, what I want to add is that I think probably the next dimension we should look at is epigenomics. We already see that, which I probably did not emphasize enough, the cluster one that I show that have DNA hypermethylation in the CPG island. Actually, one of the biggest sort of, if you like, the group of genes that are associated with is all related to PRC2 complex. Again, pointing to the but perhaps the usefulness of epigenetic drug like EZH2 inhibitor. Yeah, thanks.
Shup.
Shup Saha from Precursor, Seattle. I had a question for Vikram, actually, who I think is just at the table over there. My question was about your precursor lesions. You mentioned for the hepatic type cholangiocarcinoma, the two precursor lesions are the von Weinberg and the bile duct adenomas. And then I think you mentioned that the bile duct adenomas are universally BRAF mutants. But intrahepatic cholangiocarcinoma, BRAF mutations are very rare. So I'm wondering if you think that the vast majority arise from the von Weinberg complexes, or if there's another precursor lesion that maybe we haven't identified yet.
Yeah, thanks for that question. So I think precursor lesion and cholangios are really hard to study because, one, we don't get that many resections, at least not in the part of the world where I come from. And two, the lesions are so large when they come out, they wipe out the precursor lesion. So the one precursor lesion that we can study really well is bilin, because we invariably have a fair amount of bile duct epithelium. We almost very rarely see either bile duct adenomas or one-member complexes. That said, there are well-established cases where we've seen some too, where we've seen this progression. We haven't quite worked out the genetic progression, unfortunately. Yes, they do. The bile duct adenomas do show BRAF mutations. And the hypothesis is that very small proportion of cholangios that show BRAF perhaps progress from bile duct adenomas. So while the bile duct type of cancers probably come from bilin, I think the vast majority of the hepatic type of cholangiocarcinomas, we are still unsure as to exactly where they come from. And at least in our hands, the background livers tend to be completely normal. There isn't fibrosis, there isn't inflammation. So it's as if they pop out of nowhere. So that's a very interesting area of study. And unfortunately, I think mouse models are going to be the answer, because studying the human disease under the microscope is not going to be the answer, because that big tumor just wipes out the precursor lesion completely.
So we'll have Dr. Gores, then Dr. Gretton, and then in front here.
Yeah, I had two hopefully quick questions. One for Dr. Binte. So you mentioned it, but in HCC, the intranodule heterogeneity is enormous. What do we know about cholangiocarcinoma and intranodule heterogeneity?
This is intratumor heterogeneity. We haven't actually done or studied that yet. No. Yeah.
Okay.
Sorry.
And the other one is for the pathologist. The pathologist with a sense of humor is remarkable. So yeah, there's usually nothing funny about a microscope. My question is, most of us think of this tumor as being very desmoplastic. And yet you didn't talk about desmoplastic subtype. And the histopathology you showed were largely non-desmoplastic cancers. So could you comment on that?
So it is true. Thanks for the question. It is true that the vast majority of intrahepatic cholangiocarcinomas are desmoplastic, and the bile duct type are also desmoplastic. I mean, I can't remember why I chose those particular images. It's perhaps I wanted to focus on a particular area. So that is not a true representation. I'd say 99% of cholangiocarcinomas have desmoplasia, and the desmoplasia is actually very similar to pancreatic ductal adenocarcinomas. These tumors are invariably half desmoplasia and half tumor.
Tim Gretton from the NIH. So I actually have a question regarding I read this article about the FGFR inhibitor that just came out in JCO, and I was amused when I discussed it at Journal Club with our fellows, because it's actually a selective pan-FGFR inhibitor in the abstract. So going back to this issue is, did you actually check in tumors how much the FGFR is actually targeted? And the question then is, why is it so much more effective in the fusion versus, for instance, the amplification? Was it designed that way, the molecule? Or can we learn something from this to make it more effective?
That's probably to
Yes.
me. Let's see. This is on? Yes, good, it's on. So a couple of answers to that. So yes, with any kinase inhibitor, we look in paired biopsies for pharmacodynamic impact. The issue that you're getting at there is there aren't reagents that discriminate and distinguish among phospho-FGFR1, phospho-FGFR2, and phospho-FGFR3 all that well. From preclinical data as well as specimens from the trials, we think in patients who are getting a therapeutic exposure that we have pretty good suppression, not perfect suppression, but demonstrable 90+% suppression of FGFR signaling. So I think we're on target. I think The question about therapeutic responses has more to do with, I think, whether the tumor is actually addicted to FGFR signaling or not. I think it's the vast majority of cases in the amplified setting that the tumor is not dependent on FGFR signaling. There was no drug design that would target amplifications more than mutations or fusions. The fusions, at least epidemiologically and biologically, appear to be the best correlated with FGFR dependency, both in cellular and animal models, as well as in patients. And the mutations are very heterogeneous. So there are well-characterized activating mutations in the kinase and extracellular domains that are very well correlated with responsiveness and dependency. But these often occur in high background mutation tumor types where many of the mutations are really variants of unknown significance, and that's muddied the water demonstrably. So I think it's more biology than a feature of the drug. At least for our agent, and it's true for many other agents, the IC50 against FGFR 1, 2, 3 is not very different. 4 is another story, but I don't think there's anything there. I think it is a challenge, and something that we've looked at. The structural homology is such among 1, 2, and 3 that it is a very hard path to drug discovery to develop a selective small molecule inhibitor for one for any of those as opposed to the others. That's why individuals have gone down the road of ligand traps or ADC approaches, but it's certainly something that could be considered with some of the newer technologies.
Hey, I got a couple questions more from the layman's perspective. So, just curious, what is a gatekeeper mutation, and is it relevant to treatment or to a patient? Does a patient's initial mutation impact the efficacy of a treatment? And how many, do you guys know how many mutations there are? I mean, is there just endless amounts, or? Yeah.
Great questions. So a gatekeeper mutation is basically a mutation that clashes with the drug when it's trying to bind to its pocket. Because the normal valine that's there, it's happily interacting with the BGJ compound, but when the valine is replaced by another amino acid with a bulkier side chain, it clashes with the BGJ, so it can't bind. So it just basically sticks its elbow out so the drug can't get in. And then you asked how many different mutations are there out there? Or does it matter what mutation you have?
Yeah, I was wondering that these are an initial mutation, at least in our case, it was an initial mutation, and does that impact efficacy, which mutation you have?
And do you mean like right out of the gates like an FGFR2 fusion versus do you mean a resistance mutation?
I think more the latter.
We're trying to figure that out. So some patients develop 1 mutation, some patients develop 3, some people develop 5. What is the relative level of resistance of each of those mutations? We're still figuring that out. When we did our first paper, different drugs probably have different sensitivities with different mutations. And so in the end, yes, it might matter which mutation you have in terms of what drug we choose for you next.
Yeah, I think, sorry, I was just going to add one point. I think I'm a lung cancer physician by training, so one of the ways that in the lung cancer community we've dealt with this is actually to combine multiple medicines of the same class together, just because some hit particular mutations better than others. There's always a toxicity risk there, but I suspect in the FGFR field, given some of the emerging data, that some of the drugs will work better against some mutations, some of the drugs will work better against other ones, and it's going to have to be a highly individualized approach.
Yeah, well, my question actually follows up a little bit on that point that Dr. Hammerman just made. Given that there is precedence in other tumor types for the reemergence of tumor sensitivity to drugs on which a previous progression of disease was observed, I'm just wondering here in these FGFR inhibitor-treated patients if we have any serial data that could suggest the evolution of tumors to enable, let's say, a patient who was on BGJ, did well for a while, went on to TAS-120, to subsequently go back and have benefit from, re-challenge with BGJ. And I'm also wondering if there's any rationale for sort of sophisticated trial designs that are sort of randomized discontinuation plus minus trials where, you know, you might compare, instead of simply switching a patient from BGJ over to TAS-120, you might compare that sequence to a group of patients who simply have the TAS-120 added in, you know, or discontinuation versus continuation designs. I'm just wondering if you could speak to this.
Sure, I can do either way. I'm happy to start with it. So certainly plenty of precedent, again, I'm coming back to my lung cancer crutch, for the concept that if you treat a patient with a drug, you put a certain selection pressure on that tumor will evolve in a certain way. And when you take that pressure off, the tumor will often sort of fall back towards home. So typically, the second or third response is never as robust as the first. And the better, at least in my mind, we get looking at BRAF, EGFR, ALK, other situations, the better we get at inhibiting the primary pathway, the more we drive towards non-pathway-based mechanisms of resistance, which render that approach to a little more challenging. I think discontinuation approaches have certainly been tried in GIST, have been tried in lung cancer. I think it's sort of all a question of whether you have a better therapeutic opportunity or not at a given point. I think it's reasonable to try, and I do think the attractiveness of marrying FGFR inhibitors together or with other kinase inhibitors is attractive, but the one piece I'll come back to, having done this a number of times, is the toxicity concern in doing so. In lung cancer, we've been able to do it because the third generations are so well tolerated. It's not clear to me that that opportunity exists yet for FGFR inhibitors.
Just to follow up on that first. Oh, sorry. Just to follow up on that first question, we haven't had FGFR inhibitors like long enough to really actually see the evolution of that. We just had that one patient that we described who had BGJ and then for 6 months did not get anything and then got TAS-120. We're not sure if it was just regrowing sensitive clones or if they were resistant clones, but certainly we'd be open to trying that again, especially since some of these drugs are not, they're well tolerated in some cases.
So just because we're running behind and I'm getting texts here, if people can keep very short questions and short answers, and of course, discussion can be extended outside. So please go ahead.
Hi, Gary Goldstein. My wife has stage 4 intrahepatic cholangiocarcinoma, and I'm a practicing internist. My question is about BAP1 mutation. I see it on a lot of slides. It looks like the relative prevalence of BAP1 is actually high compared to, of course, the other mutations. I haven't heard about drugs, treatments, research, so I'm interested. BAP1.
I can just comment that there's going to be an extensive discussion all about therapies and subclassifying patients tomorrow. I can say that currently there isn't a clinical hypothesis for treating BAP1 mutant tumors, but certainly we can take that discussion up tomorrow further.
I think I have a pretty good question. A question about acquired resistance to ATP competitive FGFR2 inhibitor, FGFR inhibitors, that it comes from the clinic, but I'm hoping maybe guided by the lab. I've asked Lipika this before, but before some of your more recent work, and of course, Dr. Peter. In the clinic, we find that we are sort of at a struggle between higher dosing versus delays, and it looks like some of the ATP competitive inhibitors have taken the dose interruption strategy to recover from toxicity, like BGJ with a higher dose than a week off, and others a more tolerable continuous dose without a break. And that, of course, begs the question of which is more likely to cause these acquired resistance mutations, and can we model that to guide whether one should be doing higher Cmax interrupted dosing week on, week off, or day on, day off, from a mechanism of resistance, not just the simple endpoint of safety in a phase 1.
I'm curious from a lung cancer perspective, actually, Peter, if we know some of that data.
So there was a lot of effort in EGFR mutated patients to look at that. I think the bottom line is the best scenario is neither of those two, is to hit the target as hard as you can for as long as you can. There are interrupted dosing regimens that are sort of Cmax driven that approximate hitting it as hard as you can for as long as you can, but I think both approaches with 3 weeks on, 1 week off, as well as potentially providing exposures that aren't enough to hit pathway are problematic. So I think it's a choice between two suboptimal approaches. It certainly could be modeled. It could be assessed clinically with cell-free DNA quite elegantly, I think. It is a reasonable concept, but I don't like either choice a priori.
So if we can limit
Yeah.
to these three final questions, unless you have something to add here, and to the three people standing, but you have something to add?
No, I just said good question.
Yes, yes, so
My question is for histopathology. My name is Ruth Fedler. I work in clinical histopathology in North Texas. It was mentioned that the albumin in situ hybridization is mutually exclusive for intrahepatic cholangiocarcinoma, which can discern between intrahepatic and extrahepatic. I'm wondering if, because of the panel markers that are typically used to diagnose histopathologically, if there are any other stains that are mutually exclusive to diagnosis to help discern and possibly be on a pathway to earlier detection for intrahepatic cholangiocarcinoma.
I had some trouble following your question. Is your question, are there early markers? So albumin is not going to help with early detection. It really helps in defining a tumor as an intrahepatic cholangiocarcinoma.
So are there any studies that are out there? Like, we know that we use CK19, CEA, and possibly MOC31 or MUC5AC. We know that those immunohistochemistry markers are also positive for other adenocarcinomas. So is there anything that is mutually exclusive that could potentially help in the endeavors to have earlier detection of intrahepatic or extrahepatic cholangiocarcinoma?
You're talking at the serum level, not at the tissue level. Is that correct?
No, at the tissue level, or both, at serum or tissue.
At the tissue level, I don't know of any data, but there's several serum markers, and perhaps somebody on the panel can speak to this. But perhaps more relevantly, I think next-gen sequencing has had a significant impact, or potentially is likely to have a significant impact on early detection. By identifying early mutations in biliary samples, you could potentially detect cancers early, particularly in things like the PSC setting. But I'm not aware of serological markers that could help.
So Florence Selleru from Johns Hopkins.
Yeah, thank you. So I was wondering, how does the panel think about genetic heterogeneity that most likely occurs in cholangiocarcinomas along with other solid cancers? And so, for example, when we're thinking about mutations that emerged after treatment, how sure are we that that's not actually biopsy bias, seeing how we typically get 2, 3, 4 cores prior to treatment? Does that make a difference in the way you're thinking about this? And also, seeing how the DNA sequencing does predict or does not predict response to FGFR2 inhibitors, what is the role of DNA sequencing prior to actually giving the drug? Thank you.
I can talk a little bit about the heterogeneity. I'm sorry, I missed your second question, but I can talk about the heterogeneity. But go ahead. Sorry, your second question again was?
The second question is, how do you think about the role of DNA sequencing, seeing how we are not quite sure if it predicts response to FGFR inhibition or not? And how do we think about DNA sequencing?
So we looked at a rapid autopsy in our first case, in our first paper, and we found 5 mutations in FGFR on ctDNA. But when we looked at 12 different metastases, some from the liver, some from the lungs, we only found mutations in 4 of the tumors. And among those 4 tumors, we only saw 3 of the mutations. So I do think, we make these assumptions that the left side of the tumor looks like the right side of the tumor. The tumor in the left side of the liver looks like the same as the tumor on the right side of the liver. And the liver lesion looks the same as the lung lesion, But I think you're right. I think there is a lot of tumor heterogeneity. And at the end of the day, with patients, it's not just about treating all of the mutations. It's about treating the mutation that is in the tumor that is driving the symptoms for the patient. So if they have a mutation in the spine, or a lesion in the spine, or a lesion on the bile duct, something like that, initially at least, to get someone out of trouble, So it does pose a significant issue in the clinic when you have a heterogeneous panoply of mutations in terms of what to go after. And this is why we're more moving towards, having biopsies and ctDNA potentially especially for a disease like FGFR positive cholangio, so you can get information from both. I'm in favor of genetic sequencing just because we do pick up these FGFR2 fusions, and while not everyone responds, certainly many people do respond. And certainly there are other mutations like IDH mutations and other mutations that we have drugs for. We're looking at our own MGH population of people that we've sequenced, and you're right, out of around 300 patients that we sequence, about 60 of them may go on a clinical trial, and of those, maybe 10 to 15 will derive significant clinical benefit. And so when you look at the proportions, but at the end of the day, we try to do everything we can for those 10 or 15 patients. You always hope that you can find a mutation that you can target.
Thanks. So just final question.
Yeah, quick question for Dr. Deshpande. So we learned today the common risk factors between hepatocellular carcinoma and cholangiocarcinoma. You nicely summarized the bile duct type of cholangiocarcinoma and the hepatic type. We might not know the answer, but is there any association, or in other words, are there more prevalence of diabetes, obesity in patients with the hepatic type as compared to the bile type?
So the question is, are you referring to NASH-related?
Well, I'm talking about you mentioned there's two types, bile type and hepatic
Correct.
type cholangiocarcinoma. So in patients with hepatic type, do they have more prevalence of diabetes, obesity compared to the bile type?
So I don't have that data. We did try and look at NASH, which is non-alcoholic steatohepatitis, in the two types. We could not identify, at least histologically speaking, an increased incidence of NASH in either of the subtypes. Most of our cholangiocarcinomas, the background level looks completely normal. We have not looked into the clinical findings in these cases.
So thanks to everybody for the great morning session. Is there any announcement now? Do you know, Katie? Lunch? Come back at 2. Lunch is next door? Got it. Okay. So lunch next door, and back at 2, please. Thank you. Really enjoyed working with us. Thank you for taking the time to come. Sorry.